everybody. Good evening. I'm Greg Hallstrom. I'm one of the owners of H&D Physical Therapy, and thank you for taking the time out to join us for another one of our webinars. Just want to introduce you to Kaitlyn Parrotte, who has had experience working with individuals experiencing bowel, bladder, and sexual dysfunction and pelvic pain, as well as women during pregnancy and postpartum, both men and women post-pelvic surgery, and adult and pediatric orthopedic populations. Katie is also the chair of the Greater New York District of the New York Physical Therapy Association. She's on the board of directors and executive committee for the chapter as well. Katie also serves as vice chair of the International Pelvic Pain Society Research Committee. She's chair of the governance committee for the APTA's Academy of Pelvic Health Physical Therapy, and the chair of the Judicial Reference Committee for the New York Physical Therapy Association. Katie's an active participant in advocacy efforts in the local, state, and national efforts to improve patient care and access, as well as help to strengthen the physical therapy profession overall. Additionally, she recently completed a master's in epidemiology from Columbia University to begin contributing to research in pelvic health to promote community awareness and help raise the bar for quality of care. In between all of that, she finds time to work full-time and serve as the clinical director at H&D's Upper East Side Clinic and the program director for H&D's pelvic health program as well. So without further ado, I'm gonna have Katie take over the floor. And again, feel free to chat your questions along the way, and then after the presentation, we'll open up the floor for where you could ask Katie some questions directly. Okay, and it's all you, Katie. Thanks again.
Great. Thank you, Greg, for the introduction. Welcome, everyone. It's nice to see you all here. So I'm going to share my screen here. So the purpose of this presentation is just kind of give a broad overview of pelvic pain. It is a very in-depth topic area. There's a lot of directions we could spend hours talking about. So the purpose today was just to give you kind of a general understanding of pelvic floor anatomy, to help you become familiar with some of the diagnoses that relate to pelvic pain, to learn how pelvic floor muscle dysfunction can play a role in pelvic pain, and to understand the role of physical therapy in treating pelvic pain. And as Greg mentioned, there will be time for questions at the end, so jot them down, put them in the chat. Certainly you can ask the question at the end, but it'll just be easier to get into more of a discussion after we go through this. So what I want to start with first is just some statistics here. So just to give you a sense of prevalence, so 1 out of every 4 women experience pelvic floor dysfunction. Up to 43% of all women suffer from dysporunia, which is a diagnosis of pelvic pain that we'll go over a little bit later. 88.3% of men with non-bacterial prostatitis present with pelvic floor Malaysia and/or pelvic floor dysfunction. And chronic non-bacterial prostatitis affects 2 to 10% of men and accounts for 90 to 95% of prostatitis cases. So this is just to help give a sense that you know, this is something that is more common than a lot of us realize. I think especially with the, you know, sexual function and genital region, the pelvic region in general, I think is traditionally a little more of a taboo topic, and people aren't as comfortable talking to each other about it, talking to their healthcare provider about it. I found a lot of patients I treat feel very isolated and kind of feel like they're the only person going through this. So I think it's important to see numbers like this and realize that a lot of people are, you know, a lot more people I think than we think are dealing with some type of pelvic pain or pelvic floor dysfunction. Unfortunately, it is something that is becoming more talked about, and more healthcare providers are becoming familiar with it. So I think more people are getting help earlier, which is great. So just start, I want to just provide an overview of the pelvic floor muscles, just give you an idea of anatomy. So the pelvic floor is actually 3 layers of muscle. So it sits between each half of the pelvis and is a hammock of muscles at the very bottom of our pelvis. So we have layer 1, which is this triangle of muscle here. So we have 3 muscles, the superficial transverse perineal, the bulbous cavernosus, which in females it slings around the vaginal opening, and the issue cavernosus, which are muscles that top the triangle here. We also have the external anal sphincter, which is surrounds the anus toward the back of the pelvic floor. There's my picture of male anatomy. So for males, it's the same 3 muscles are there. You have the issue cavernosus on top, the superficial transverse underneath, and then for men, the main difference is the bulbocavernosus, sometimes called the bulbospongiosus muscle, is connected through a common tendon, and it goes from the perineum to the base of the penis. So that's layer 1. It's also called the superficial perineal pouch, if you're interested. So then layer 2, we call it the urogenital diaphragm. So in both men and women, there is deep transverse perineal muscles that go across, and the external urethral sphincter, so that helps to control urine flow. And then in women, you have the sphincter urethrovaginalis that slings around the urethra and the vagina, as well as the compressor urethra. So this layer is more important for urine flow. And then layer 3 is we call the pelvic diaphragm. So you have 2 main muscle groups. You have the levator ani muscles and the coccygeus muscles. So the levator ani muscles are here, and then the coccygeus are here. And then the same in the male model. We have levator ani here, and then the coccygeus here. And then you also have a pelvic wall. So you have the obturator internus and the piriformis muscles. So interestingly, with these muscles, these are actually both hip rotating muscles. So I've had a fair amount of patients who come in with like persistent chronic hip pain. And it turns out it's actually driven to a degree from their pelvic floor dysfunction. So working on pelvic floor muscles, pelvic floor coordination, and general core strength has helped many people with hip pain. And this is why, because it's very closely connected. So also just want to run through just some general pelvic floor function in case people aren't sure of everything the pelvic floor does. So we have the urogenital triangle here, which is the first 2 layers really of the pelvic floor. So these muscles close the urethra, close the vagina in women, and they help to maintain clitoral or penile erections. And then we have the anal triangle toward the back, and this helps to close the anus for bowel control. And then the layer 3 muscles are the pelvic diaphragm. So these are really support muscles of the pelvis. They help support the abdominal organs, so bladder, prostate, the vagina, so that they stay in place. Also, the pelvic floor is part of your core system. I think it's an often overlooked muscle group in your core system. So research has found it helps to fix the trunk when you're doing arm movement. So it's providing some stability. And just kind of a fact with the muscle fibers, so we have both fast and slow twitch fibers. So what this means is fast twitch muscle fibers are kind of our moving fibers. So like our biceps, our quads are really the muscles that help us move, and those are our fast twitch muscles. And then we have slow twitch muscles, which are more of our stabilizing muscles. So the pelvic floor has both, but more of those slower twitch muscles. So that just shows us that it is very important for the stability of our system. And when it's not working, our stability is often a bit awry. So there's a lot of different signs and symptoms of pelvic pain that person can present with. And so this is really just a general overview. This is certainly not an extensive list, but these are some of the more common signs and symptoms of pelvic pain. So just some pain locations and descriptions. So pain around the external genitalia. So in women, pain at the clitoris, pain in the vagina, in men, testicular pain, penile pain, pain in the perineum, which is the area between vagina and the rectum in women, and between the base of the testicles and the rectum in men. Vaginal pain in women, as I mentioned, also anal pain in men and women. Some folks will complain of deep penetrative pain. Also bladder and or urethral burning pressure and pain are some complaints. And so as far as pain descriptions, it can really vary. And you can kind of see here, burning, sharp, shooting, stabbing, knife-like, tearing, aching, dull. So the type of pain that you're experiencing can really vary depending on what your diagnosis is and just how your body perceives pain. I would say very commonly, I hear a lot of like burning pain as a descriptor, especially if people are experiencing irritation in the pelvic nerves. And then pain-inducing activities. So once again, these are just more common activities that my patients that I've seen have complained of. It's certainly not an extensive list, but it just gives you kind of a good overview of the different types of situations you might have pain in. So intercourse, during or post-intercourse, post-orgasm or ejaculation, with urination, with bowel movements, also sitting, especially for a longer period of time on harder surfaces is often more challenging for people. For some folks, wearing tight-fitted clothing can be really uncomfortable. And for other folks, exercising, walking is what tends to bring on their symptoms more. So it really can vary, but these are kind of some of the bigger ones that I tend to see. So this list is just a list of some of the more common diagnoses of pelvic pain that you may hear, or you may, if you're experiencing pelvic pain, be diagnosed with. There's a few of these that I'll go a little more in depth on. So Pudendal Neuralgia, Levator ani syndrome, pelvic floor tension Malaysia, coccydynia, proctalgia fugax, which is like a severe spasm of muscles in the rectum. Post-surgical or scar adhesions can be painful. Interstitial cystitis or painful bladder syndrome, fibromyalgia, bowel disorders like IBS or colitis. So some conditions that are unique to women, vulvodynia, vestibulitis or vestibulodynia, Dysporunia, and endometriosis. And then some conditions more unique to men, non-bacterial prostatitis, prostodynia, which is a type of non-bacterial inflammation in men of the prostate, ejaculation pain, penile and testicular pain. So as I mentioned, I'm just going to pull out a few of these more common diagnoses and kind of give a broad overview of how they present, what they feel like for people. So Dysporunia is a condition that occurs in women. It's pain with vaginal penetration. So it can be pain with initial penetration. So with that, there's usually a restriction to the vaginal opening. So tight muscles restrict blood flow, which can lead to a burning pain. They also can have pain with deeper penetration, which is due to muscle tightness and trigger points. This can present as pain during intercourse. It can present as pain after intercourse, and this would be more of like a reactive pelvic floor spasm due to intercourse. Also pain with orgasms. So orgasms are followed by a rhythmical pelvic floor muscle contraction and relaxation. And if there's an underlying tension of these muscles, the pelvic floor can kind of get stuck in a spasm and after orgasm and lead to pain. Non-bacterial prostatitis. So this would be something that only occurs in men. So, and if you recall, the research is showing us that 90 to 95% of men who've been diagnosed with prostatitis have non-bacterial prostatitis, so non-bacterial inflammation or an inflammation of the prostate without an infection. So the presentation can be kind of broad with this of where men are experiencing pain. So they can have pain in the anus, in the rectum, around the tailbone, in the abdomen, which tends to be more referred pain from the pelvis, bladder, in the perineum, in the groin, or in the genitalia, like the penis or the testicles. So also urinary hesitancy, frequency, urgency, or slower weak stream, and complete emptying are often go along with non-bacterial prostatitis. Pain with urination can also go along with prostatitis, as well as difficulty or painful ejaculation. So with this tight pelvic floor muscles can cause like a chronic irritation of the pelvic nerves, decrease in blood flow to the perineum, and radiation of pain into the pelvis, abdomen, and genitalia. And so one thing especially with the non-bacterial prostatitis that I'll see with a lot of men is, a good sign that it may be non-bacterial is if you've had 1 or 2 courses of antibiotics and you still have pain and it hasn't changed your symptoms, then it probably is not inflammation due to an infection. I have unfortunately seen male patients who've had multiple courses of antibiotics over years sometimes before someone mentioned like, oh, it might be your pelvic floor. So if this is you and you've had pain and you've tried medication and it hasn't changed your symptoms, then looking into maybe pelvic floor dysfunction I think would be a really great idea. So another diagnosis, and this is something that can occur in both men and women, is pudendal neuralgia. So I just want to give an overview of the pudendal nerve. So this is the main nerve of the perineal area here. So it carries sensation to the external genitalia, men and women, as well as around the anus and the perineum. And it provides the motor supply to the pelvic floor muscles. So it's the nerve that allows the pelvic floor muscles to work. So this is a really great picture. It goes over a couple of other nerves. We don't need to worry about them. So the pudendal nerve, we can see the distribution in pink, purple, and more of this like maroon color. So there's 3 branches of the pudendal nerve. You have the dorsal branch in pink. So for men, it provides sensation to the penis. For women, around the clitoris. You have the perineal branch. So in both men and women, it kind of starts around the clitoris in women and goes to the perineum, so it goes along the labia for women. And in men, it starts at the base of the penis, provides some sensation in the testicles, and then feeds down into the perineum. And then the inferior or rectal branch in both men and women really goes from the bottom half of the perineum around the anus, and that's a similar distribution for men and women. And with this model of this picture here, it's because it's showing multiple nerves. It kind of might seem that the pudendal nerve is only on one side, but this is a nerve that is bilateral, so it is on both sides, and the distribution would be the same. So pudendal neuralgia. So it's pudendal nerve pain, and this pain can radiate to the rectum, the perineum, the clitoris in women, or the penis in men. So typically this is symptoms that are only on one side. In severe cases, I have definitely seen folks who have pudendal neuralgia on both sides, but a lot of times if someone has pain on both sides, we're suspicious that something is happening higher up the chain, maybe closer to the back, because often the pudendal nerve is grumpier and more inflamed on one side when they come into the clinic. So common pain pattern for this is an increase in pain with cycling, sitting, bending forward. These are all activities. The cycling and sitting are activities that put direct pressure on the perineum, which can be really irritating. With bending forward, especially if the restriction in the pudendal nerve is a little more higher in the pelvis, bending forward can cause some compression on the nerves. A lot of times folks with pudendal neuralgia will report they feel better in standing or if they sit on the toilet. And this is because standing, you have no weight on the perineum. If you're sitting on the toilet, there's a circle, so your perineal area is pain-free. And also a lot of times people will report that they don't have any pain at night. And this is because they're relaxed, they're able to lie supported, and they're able to lie with their spine in neutral and no pressure on the perineum. So they often will feel better in that position. There's several areas of irritation along the path of the pudendal nerve that can be irritated from the sacrum to the pelvic floor. So it takes a little bit of detective work to determine where along the pathway of the pudendal nerve folks are having the compression, and that's figure out where is the actual problem arising from. So some possible contributors to irritation could be posture and alignment. So if you especially you're sitting really slouched over, there's areas from the low back into the pelvis that can be compressed. Tightness in the hamstring or obturator internus, because the hamstring tightness can contribute to pulling your pelvis out of alignment. And then the obturator internus can add to compression of this nerve, as well as general pelvic floor muscle tightness. So there is an area in the pelvic floor where the pudendal nerve actually peaks out. And so if the pelvic floor muscles around it are really tight, it can get compressed in that area. So interstitial cystitis or painful bladder syndrome is a chronic pelvic pain or pressure perceived to be from the bladder with urinary symptoms. The pain increases typically as the bladder fills, and often patients will report their symptoms feel better when they urinate. So this is a defect in the protective mucosal lining of the bladder, which allows substances, often potassium, in the urine to irritate the wall. So a lot of times folks who have IC or painful bladder syndrome are recommended to go on a specific diet, which eliminates a lot of the more irritating foods and beverages to the bladder. Levator ani syndrome. So this one's a little more specific to musculature. So the levator ani, if you recall, is the part of the layer 3 of the pelvic floor. So it's this sling of muscles as well as these two here, the iliococcygeus muscles. So it's a hyperactive pelvic floor. It restricts normal tissue mobility, can inhibit blood flow, and irritate the pelvic nerves. And then it promotes poor pelvic alignment and core stability, because when you have pain, your core tends to turn off. And so folks with levator ani syndrome often, in a lot of cases, they'll report that they have a feeling of like a golf ball in their rectum, or pain deep in the vagina. And that's just because of where those muscles sit. It usually feels like it's a deeper pain in the pelvis. Pelvic neuralgia is very similar to levator ani syndrome. It's a little more broad than just the levator ani. A lot of folks with this diagnosis have a lot of tightness throughout their pelvic floor. And so it is kind of a sequela of symptoms with Malaysia. So they have tight muscles in the pelvic floor, and that develop into trigger points, which cause a radiation of pain. So the muscle pain, sometimes if it's at a similar level to a pelvic organ, the brain interprets that the pain is actually coming from the organ. It will send inflammatory cells to the organ. So there are folks who have pain and irritation in the bladder, in the prostate, in the uterus or the rectum in some cases. And it's because the brain is getting confused where exactly the pain signals are coming from. So really severe pelvic floor trigger points can cause just kind of an inflammatory response in the pelvis in general, and folks kind of have a really broad range of symptoms. So this is really related to like a neural upregulation. So like the nervous system just gets hyperactive in these cases. So the tissue mobility is restricted. the blood flow is inhibited. So that leads to nerve irritation and local inflammation. So you have higher pain sensitivity of the muscles and a decreased threshold for pain. The sympathetic nervous system, which is like your fight or flight nervous system, gets on overload. So you're kind of always in that fight or flight phase. So basically you get some sympathetic input, the muscles tighten, they hold, they create pain for you, and then that pain triggers more input from your sympathetic nervous system, more of that fight or flight response. So then the cycle just continues. So it's called Malaysia because it's kind of a more broad presentation of pelvic floor pain, and it really does cause a lot of other symptoms because it pulls in that nervous system just getting really upregulated. Oops, sorry. So, okay, so at this point, what I want to do is switch gears and just kind of talk a little bit more about physical therapy interventions. So obviously the last couple of diagnoses we talked about were really specific to the pelvic floor, but in the case of non-bacterial prostatitis, Dysporunia, the interstitial cystitis, painful bladder syndrome, Pudendal Neuralgia, the pelvic floor muscles in a lot of those cases, if not all that I've seen for sure, get tight and irritated. So the pelvic floor is sometimes the driver of pelvic pain, and sometimes it is a response of pelvic pain. But whether it's comes first or second, it's really important to work on improving the muscle mobility of the tissue, because once it's tight, a lot of times it doesn't release very successfully on its own. So folks may need some medical interventions, but in most of those cases, even if pelvic floor dysfunction comes on later, it is important to have some direct work to help release that. So for physical therapy, what we can do, and this is just kind of a broad list, obviously anything any intervention that is done will be tailored to any one individual's needs. But patient education, a lot of folks that I see aren't very familiar with the pelvic floor, or they're just getting exposure to the pelvic floor because they're starting to have problems. So we talk about anatomy, physiology, what's causing their symptoms, what the diagnosis means. Certainly getting into habits and lifestyle, diet can be really important for some people. Postural re-education. So because the pelvic floor sits in between the pelvis, alignment of the pelvis itself can have a major impact on the pelvic floor tension. The hips also play a huge role. Once I stop sharing my screen, I actually do have a pelvic model, so I'll be able to show you a little better, just so you can kind of get a better sense of the relationship between the lower extremity and the hips and the pelvic floor. And certainly the trunk and spine. So if you're really limited in spine mobility, and that creates kind of a tipping of your pelvis, that can also change the length tension relationship of the pelvic floor and put more stress on the pelvic floor muscles. So we would want to talk to you about, how are you sitting? How are you standing? How are you lying in bed? Certainly any position that is causing pain is important to address, but then also just for general maintenance and to prevent a position from being problematic, we want to just work on optimizing your alignment and support. And so alignment correction ties in with postural re-education. Sometimes people need more direct hands-on work to help achieve a certain posture. So you might need some mobility in the hips, or stretching in the hamstrings to allow your pelvis to be more upright when you're sitting, or some release of the ribs to allow the rib cage to sit a little more directly over your pelvis. We would do a general pelvic floor muscle evaluation to get a sense of, are you having pain or tension in the pelvic floor? And if you are, what specific muscles, so we can help tailor our treatment. Talking about relaxation techniques is very important, because the pelvic floor is very responsive to stress. And when you're in pain, it's stressful and can be really anxiety producing. And so that can kind of just create this endless cycle of you feel stressed and anxious because your pelvic floor or your pelvis or your genitals hurt. And then that increases your pain, which makes you feel more stressed and anxious. So trying to kind of break that cycle is very important. So, talking about meditation, mindfulness, using heat or hot baths to help you relax can be really helpful. Using biofeedback, so that is a device that can be used externally or inserted into the vagina or rectum, and that allows us to help train the pelvic floor. Either a lot of times with pain, we need to train the pelvic floor to relax, but if we're strengthening, it gives you feedback on how to tighten the muscles. This is something that is available to us, and some practitioners use more than others, but it's one of the options in our toolbox. So therapeutic exercise. So stretching is a big one, especially stretching the inner thighs, stretching the general area around the pelvic floor, stretching the hips, especially the hip rotator, stretching the back, making sure that we have as good of mobility around the pelvis and pelvic floor as we can is really, really helpful. And eventually strengthening. So a lot of folks who come to the clinic who have pelvic floor dysfunction, no matter what the baseline is, have a lot of weakness in their core muscles, have weakness in their hips, especially like their glute muscles. So those muscles are very important for general pelvic girdle stability. So we want to make sure we're strengthening those muscles to optimize your stability. But also, because the pelvic floor is also a stabilizer of your trunk, if your core and your hip muscles aren't doing the job they need to do, your pelvic floor will tend to grip even more and go on overdrive. So it's very important to strengthen around the pelvic floor so that it doesn't have to work so hard. And then eventually, when we get the pelvic floor to relax and get to a good resting position, we do want to help strengthen those muscles again so that they can work efficiently and not fall back into a spasming pattern. Neuromuscular reeducation. So diaphragmatic breathing is a big piece of this. It can fall under that relaxation techniques because, you can even think about if you're really stressed, a lot of us just instinctually kind of take a deep breath in. It just is like a very natural, easy way of getting from our fight or flight stage to a little more of a relaxed state. But also with the pelvic, related to the pelvic floor, if you take a diaphragmatic breath efficiently, you actually should get some lengthening of the pelvic floor. So it can be a really nice way to help introduce some length to the pelvic floor in the early days. And then eventually getting to more PFM is just an abbreviation for pelvic floor muscle. So getting good coordination of these muscles. So I think a lot of us have probably heard of a Kegel, where we're tightening the pelvic floor. And we, are very often told, especially like after women have babies or like do your Kegels. The downside to just jumping to doing Kegels with is that if we don't know how to do them properly, it's very easy to get tightness in the pelvic floor. And if you already have tight muscles, doing more Kegels can make your muscles even tighter. Certainly, so the Kegel is closing of the anus and or vagina and lifting. But actually, we also should be able to not only close and lift the pelvic floor, it should be able to relax back to its baseline without any delay. And we should actually be able to lengthen the pelvic floor. So this is something we see more, just to give you context of function, of when you're having a bowel movement, you're kind of bearing down a little bit through your abdomen. If your pelvic floor is working efficiently, it actually should lengthen a little bit to allow stool to pass more easily. So we want to get back all three positions in both the shortening contraction and the lengthening contraction of the pelvic floor. And if people are tight, we're working on that relaxation and lengthening piece first. So also manual techniques are can be very helpful with treating different types of pelvic pain. So myofascial release, soft tissue mobilization, joint mobilization, for instance, around the hips, the sacrum, the sacrococcygeal joint. certainly doing direct work on the pelvic floor and direct release of the pelvic floor muscles is very important. But for a lot of folks, we need to work on releasing tension in the hips or the hamstrings. We need to work on releasing tension in the low back to help optimize that pelvic alignment, to help optimize the hip mobility so that less stress is put on the pelvic floor. So really, it should really be a big picture kind of whole body approach, not just focus on the pelvic floor to help serve your needs. Also, there's a fair amount of folks who I've treated through the years who have abdominal tension and trigger points that really is stemming from referred pain from the pelvic floor. So doing skin rolling and abdominal massage can also be really helpful for those patients. Other interventions, there are some different home devices that we can help train you in to help you be able to do some self-care on your own in between sessions. So dilators, here's a couple types of dilators here. So dilators are an internal vaginal device used for vaginal and pelvic floor muscle stretching. So you can see a little easier with the picture on the right that they're graded in size. So they start shorter and smaller in circumference and gradually increase to a longer length and circumference. So it's something that, if women, especially if they have pain with intercourse, have a hard time with the gynecological exam, we can help train the pelvic floor to tolerate more stretch to make those activities easier and not painful. Wands are another option. So this is a vaginal wand pictured here. So this is an internal pelvic floor muscle massage device. As I said, this is a vaginal wand because it's thicker, but they also make thinner ones that can be used rectally. So this is something that men can use for internal trigger point release. Massage stick or foam roll, probably many of you are familiar with foam rolls, but they're external massage devices used for relaxation and lengthening of muscles and fascia or connective tissue. So as you're probably getting the picture from what I've talked about with interventions, obviously treating areas outside of the pelvic floor are also very important to managing pain. And massage balls, so they're better for like trigger point release and general myofascial release, or kind of more pointed release than you're going to get with like a foam roll. So this is just a little bit of evidence for physical therapy and treating pelvic pain. So in one study, they found that physical therapy reduces muscle tension and spasm, decreasing pain levels by 40 to 60% in women with vulvar pain. Manual therapy to pelvic floor muscles resulted in marked or moderate improvement in 70% of patients with IC or painful bladder syndrome. And there was also notable reductions in pain, neurogenic triggers, and central nervous system sensitivity. And then another study found that physical therapy can improve introital flexibility, retain dysfunctional pelvic floor muscles, and significantly improve post-contraction relaxation. So there's definitely some good evidence that's been put out of physical therapy being really helpful for treating pelvic pain. And one thing I think is important to remember, that treating pelvic pain, certainly physical therapists, we can do a lot to help, but we are not kind of on our own island. So really a multidisciplinary team is often the best approach. So just some different practitioners who may be helpful if you're experiencing pelvic pain in your journey is urologists, gynecologists, or obstetricians, if, especially women are having pain postpartum, an internist, gastroenterologist, physiatrist, neurologist, or a pain management specialist, especially if you're having a lot of nervous system sensitization. Psychiatrists or mental health therapists can also be really, really helpful in your journey of pelvic pain. Certainly some people's pelvic pain is triggered with trauma, so having a mental health practitioner helping that patient is critical. But also for so many people, they're stressed, they're anxious, and whether stress and anxiety are somewhat of the source of the pelvic pain, or they're just having stress and anxiety as a result of pelvic pain, being able to talk to a mental health practitioner can be really, really helpful in just helping to reduce that and calm your system down. Also, acupuncture can be really helpful for patients. So I definitely have patients who are doing acupuncture along with physical therapy. And there's some acupuncturists who are trained to work directly in the pelvic floor. So doing like needling and the perineum. And I've had patients get a lot of relief from that. So it can be a really nice adjunct. So at this point, I want to open it up to questions. So I'm going to go ahead and stop sharing. And I said, if people do have questions, I have a pelvic model, so I can pull that out to give a little more context. So I know I know people have different comfort levels, so feel free to speak up if you have a question, or if you're more comfortable, you can just type it in the chat, and Greg or myself can read it from the chat.
Thank you. I have one question, Katie, to get us started. So if someone is experiencing pelvic floor pain, what would you suggest they do first?
Yeah, I think that's a great question, Greg. So as I mentioned that, it's best, most people really need kind of a multidisciplinary approach. And with pelvic pain, you certainly want to rule out any source of infection. There are, for both men and women, infection. So I think it is really great for people to go to their gynecologist or urologist, a medical doctor or a physiatrist first, just to rule out any source of infection. Certainly if someone is pregnant or immediately postpartum, going to the your OB is a really great option, just because they have been with you throughout your journey. Also, if someone is pregnant or like immediately postpartum, I always want to have clearance from their OB to do internal pelvic floor work, just because they're more aware of any potential risk factors for that patient than I am. So I think going to a doctor first, if you have that relationship, is a really great place to start. Because also for a lot of folks with pelvic pain, a medical intervention is really necessary. So whether that be an oral medication, suppositories, which are often muscle relaxers that you can insert vaginally or rectally. So a lot of times we need more than just pelvic floor PT. Having like a medical intervention can be really, really helpful for people. And if you don't know who to go to, certainly you can go to a physical therapist who is, really in depth in this field. It should be able to direct you to some good practitioners in the city, because I know that process can be overwhelming.
Thank you, Katie. Stacy has her hand up, so I'm going to ask Stacy to unmute, and then
Mute.
there you go.
Can you hear me?
Yes, we hear you.
Okay. I've been listening, and I've had this for the last, I want to say, years. But medication was working. Now it's not working. Mm-hmm. Every doctor I know can't come up with an answer. I've been to my internist, OB, 3 urologists, going on to my 4th. I've used the suppository and it only works for a few hours. Mm-hmm. I'm fed up. I'm raising a child and she complains that I'm not spending enough time with her because I'm always in the bathroom.
Sure. So, I think without knowing, any specifics of, the symptoms you're experiencing, I will say that it's not uncommon for folks who, even if it started out as an infection, and I've definitely seen, women with bacterial vaginismus, men with, a bacterial infection of the prostate, there are that do respond to medication. Sometimes what can happen is your pelvic floor can actually spasm in response to the infection. Urinary tract infections also can do this for people. So I've had people come in, they've had UTI symptoms, they feel they have like a confirmed culture, they have a UTI, they take medication and it helps. And then all of a sudden these UTI symptoms keep coming back, but it's no longer showing that they're positive on the culture. And what can happen in some people is just the pelvic floor spasms in response. And so that can contribute to a continuing pain cycle, and your brain can get a little bit confused. So it can feel like you're having symptoms of an infection, but it's actually your pelvic floor that's kind of causing your nerves to go a little haywire. Also, what happens when you have pain for a long period of time is it really kind of gets ingrained in your nervous system. So your nervous system really gets upregulated. And that was kind of, I talked about that a little bit with when I went over the pelvic pain, the pelvic floor Malaysia, where your nervous system can just get really hypersensitive. So the muscles, the nerves, everything just gets more reactive, and you have pain to things that shouldn't be painful, or more pain to things that are painful but shouldn't be as painful as you're experiencing them. So it really, after you've had pain for a long time, it really can really kind of set into your system, and you get into this hard cycle. So working on the myofascial system, the muscle system, having that evaluated and seeing if that is playing a role, I think could be a really helpful place to go, especially if you're finding that medical management is kind of hitting a dead end.
Yeah, because I was on 3 different medications. Some worked for a little while, some didn't work at all. I am using the suppository, and it helps for a few hours, but like only halfway through the night. I'm at a pelvic floor physical therapist and a pelvic floor, what is it? Like behavioralist.
Oh, okay.
And so far, absolutely nothing is helping.
I mean, without that, it's kind of a general overview.
Right.
Without, as I said, I think without, if I can put my work email in the chat here too, without being able to speak a little more specifically of like symptoms you're experiencing, I don't really know what other advice to give you, but I'll put my email in the chat. And if you would like to reach out to me, I'd be happy to you're
the first person to fully explain what's going on in general to me. So
I'm just making sure I typed it correctly. So
I appreciate that.
Parrotte at hdphysicaltherapy.com, and this can be for anyone. If anyone has any questions, feel free to email me. But I said for you, Stacy, I just, without knowing more background, I don't feel like I can give you more advice. But I'd say I think the best thing would be email me, and we can.
I will.
A time to maybe talk on the phone and go from there.
Thank you.
No problem.
Thank you for asking the question, Stacy. Can you, Katie, explain the connection between pelvic pain and the SI joint?
Yes. So give me a good reason to pull out my model here. Okay, let me just pull the organs out. So make sure you all kind of see that. So this is the pelvis. So you can kind of see, just to orient you quickly, the spine. This is the tailbone, so bottom of the spine. The pubic bone's in front, and you can see here, these are the hip sockets. So the hips are here. So they're in very close proximity to the pelvic floor. So we have, and then let me just point out too, the SI joints are where the pelvis on each side meets the sacrum. So that wedge at the bottom of the spine. So these are your SI joints here. So you have muscles that are deep in the low back between each vertebra, and that run along the spine that help to stabilize your spine. You also have abdominal muscles that come across and up the abdomen to provide stability. But then you can see in this model, this is really showing the pelvic floor. So what can happen, and it's usually not just the pelvic floor in isolation, but when these general stabilizing muscles all together are not working properly, or you have tension somewhere, including the pelvic floor, it can contribute to the SI joint getting pulled out of alignment. So sometimes it can be, and by the time people see me, it's sometimes chicken, or we're not sure if it's chicken or the egg. Is the SI joint out because you have tension in the pelvic floor or in the abdomen or in the back, or do you have tension in these muscles because the pelvic floor, the SI joint is sometimes out of alignment? So sometimes that can be we're not really sure of the cause, but we still are approaching the problem in the same way to work on the mechanical alignment. So what we want to do is help to get the SI joint in a better alignment and reduce tension in the pelvic floor so that you can kind of maintain this position. Sometimes you do get some referred pain. So sometimes the problem isn't necessarily the SI joint itself. Sometimes it is the pelvic floor muscles, especially this, sorry, I'm tipping to make sure you can see it, this third layer of pelvic floor. Sometimes these muscles are just tight. And so it can actually create some referred pain to the abdomen, to the low back, to the SI joint. So treating the muscles directly can help to reduce that pain.
That's excellent. Thank you.
Yeah.
Another great question came in. Can you comment on the safety and efficacy of dry needling for pudendal neuralgia? Wondering about the accurate placement of the needles and whatnot.
Yeah, honestly, for pudendal neuralgia specifically, because dry needling is not, physical therapists are not licensed to do it in New York State, it is certainly an area that I do not know much about in my practice. So I'm not super familiar with the research on dry needling specifically with pudendal neuralgia. So I don't feel I can give you a very good answer on that. But I will say that if you're going to someone, and in New York State to be an acupuncturist, you definitely want to go to someone who has experience with pelvic pain and has treated a lot of patients with pelvic pain and has experience doing it versus someone who's just kind of trying it out. But no, I cannot give you any hard information on that because it's just not my area of expertise.
Understood.
Does anyone else have any questions? I think I see.
Yes.
Henriette, yeah.
Henriette, yes.
I think you're muted.
I can unmute you.
There we go.
Thank you very much. I'm not sure that the question is to the point because it's a different part of the abdomen. It's the hernial pain.
Mm-hmm.
You have inguinal, and it seems that it develops and then it becomes very, very burning and you can't stand anymore and you really need to go and collapse. Otherwise you can, and if you do relax, then after a while you can get walking again. And
Mm-hmm.
I find it very, very difficult. I had noticed it in my mother before, and now it's on me and I don't know what to do. It's, is it related? I mean, should I contract the muscle and try to keep them in and, or should I just go and see?
So just to make sure I'm understanding you correctly, are you have like an inguinal hernia or you have pain in that area?
No, I have an inguinal area.
Okay. So a couple of things. So if it's a smaller hernia, it often can be treated with an intervention. I think when it comes to like a hernia, that is a case where talking to your doctor first and getting clearance to do physical therapy is important because they've done the imaging, they know the size of it, so they have a better sense of, if doing muscle strengthening is going to be safe for you or if surgery is the better route. So I definitely think that is a case where you want to talk to a doctor first, just because they have that imaging information. When folks do have hernias, it can go kind of one of two ways. So you can, for some folks, they do really well with working on stability, working on activation of the transverse abdominis. It is very common that both men and women who have hernias do get tension and trigger points in their abdomen, in their pelvic floor. So doing release in those areas can be very, very helpful. However, there are times, I've seen this especially in male patients, when I've had a male patient who their pelvic floor is getting better and they're still having pain, they're still having symptoms, and it's just looking hinky, it's a technical term. I often refer them to a hernia specialist or surgeon to get an assessment, and 2 or 3 times I've had patients who've ended up going and getting a hernia repair and then coming back to me, and it's made like a really, really big difference. So there's no hard and fast rule, unfortunately. And it really can go either way. Of doing stability work can be very helpful, but sometimes you do need that surgical repair. It just depends on the size and degree, because if it's a large enough hernia, if it's been there long enough that the abdominal wall and the inguinal wall is just, the structure isn't there anymore, you're just not going to be able to get that muscle activation the way you need it to. Does that answer your question?
Well, it does. Yes and no, because I was trying to see if I could do something before going to see a surgeon.
Yeah, and I mean, I think that, as I said, I think it would be, I think it's helpful, like if you know it's there, you know, if it's been diagnosed by a provider, you know, just checking with them that they feel it's safe for you to do PT, but like, definitely, I think it's worth giving PT a try, especially if you really don't want surgery. And then honestly, we'd be able to tell you, you know, change in tissue happens in like 4 to 6 weeks. That just is how long like physiological change. So, you know, after a few weeks, if we're just not seeing any change, and we can, you know, make the decision of like, okay, you know, I think you might need to do a next step, or maybe go see a surgeon, but if you're getting better, then great. So as I said, there's no set rule of who feels better and who doesn't, but especially if you know you'd like to avoid surgery if you can, I think trying PT first, as long as, you know, if there's no medical reason you shouldn't do it, is a great place to start.
Can I ask you another totally different question, something you haven't mentioned in your presentation? I have heard long ago about some kind of eggs that you would, in a very kind of precious stone eggs that you would put in the vagina, and you try to work on them to muscle the vagina and hold them, work on the. Does that help, or is this just?
I don't really. So, well, they're like vaginal weights. I don't use vaginal weights. I don't really think they're helpful. Well, honestly, a lot of people, especially with pelvic pain, most people have a tightness problem. So the last thing I want to do is start having people try to carry use a vaginal weight or work on tightening those muscles, because that can only make that spasm worse. I will say it's not, I will never use a vaginal weight, but it's a very specific situation. I find when vaginal weights are helpful is when someone, not usually pelvic pain, but like someone say has incontinence, maybe like a newer mom has postpartum incontinence, and they can run for 2 miles and then they get to mile 2.1 and they leak, and they've done everything and their pelvic floor is strong. Then vaginal weights are helpful of like, oh, put this in and take a shower, wear it for, have it in for 10, 20 minutes to build muscle endurance can be really helpful. But I think most people don't need vaginal weights. Your pelvic floor is not a muscle that's meant to move 50 pounds. So you don't really need to do weight training with it. You just need to do endurance training.
Okay, thank you very much.
No problem. Let's see, I think I saw Greg put contact information. If you would like to schedule an appointment with me, you can either call our office or follow that link to our online scheduling system. And then someone messaged me if they could send their email to, yes, you can send my email to your friend who lives in Lima, Peru. I am a member, Greg mentioned, of the International Pelvic Pain Societies, which does have members from all over the country, or all over the world, excuse me. So I could definitely reach out to that community and see if there are practitioners in Peru for your friend. So yeah, you can absolutely send her my contact information. That's fine. Does anyone else have any other questions for me?
This was a great presentation. Just want to thank everybody for taking the time to join us tonight, and then to Kaitlyn Parrotte, who's our director of pelvic floor, as well as our 88th Street clinic. And I think it did a fabulous job explaining this for us. So thank you so much.
Thank you, everyone, for coming. Oh, yeah. Thank you. Yeah, thank you so much for coming. I know it's a beautiful day, so Thanks for staying inside and listening to me talk for an hour.